Good morning, class. Let me fix my lips. Okay, so good morning, class. It is a pleasure to talk to you today about urinary collection. This is going to be a short video that is going to explain urinary collection methods and the reasons why we ask our patients to collect the urine and the type of method that the patient needs to use in correlation with the exam or the assessment that the physician needs the urine specimen for. So later on, after this lecture, you will actually collect urine and you will assess your urine and other individuals' urine in the room. So let's get started. So when it comes to urinary collection, oftentimes the patient is complaining of either abdominal issues or problems urinating. The physician oftentimes will ask you, the medical assistant, to collect a urine specimen. The way that we collect the urine specimen, or the type of method we use for collecting the urine specimen, is contingent upon the type of test or assessment that the physician is going to order. So there's different types. I want to talk to you about type number 1. It's called first morning void. Just like it is said, first morning void typically means that this urine is collected first thing in the morning when the patient generally wakes up. The test that correlates with a first morning urine would be a pregnancy test. This is because the HCG, the human chorionic gonadotropin hormone, is at its highest levels first thing in the morning. Think of it this way. When a person is sleeping, everything settles in their bladder. I don't care if they're on drugs, have prescribed medications in their system. Anything that is in the system settles in the bladder and we void it out in the morning. So when there's an increase in certain hormones levels, we will be able to see that increase first time the patient urinates in the morning. So when a woman is in her earlier gestational period, it is advantageous for us to get urinary collections first thing in the morning. This type of urine collection is known to you as a first morning void. The second type of urinary collection that I'm going to speak with you about is called random specimens. A random specimen can be utilized, and it simply is what it sounds like. It is random. This specimen is generally given throughout the day, meaning the patient could come in at any time of the day and get and we are able to collect the urine from them. So a random urine is typically used for drug testing. Okay, drug testing is a medical legal event, or medical legal events are events that are followed with a chain of custody and usually ordered by a regulatory agency, whether that agency is the court of law or an employment agency. But these type of events, medical legal events, must be accompanied with a chain of custody. The chain of custody requires a different type of consent. This is where express consent for the urinary collection is very important. This simply means that the patient is going to sign their name to the chain of custody form, giving us permission to collect the urine. This chain of custody also follows the patient throughout the course of us obtaining or keeping their urine. So as long as the urine is in our custody, and whoever custody that the urine actually is receipted into, they also must sign the chain of custody. Think of it like this. I have a cup, and everyone who touches this cup must be a part of that chain of custody. So when it leaves my hand and I give the cup to someone else, the next person who receives the cup must sign the chain of custody. This chain of custody is a tracking method to make sure that by the time the legal or judiciary system gets the results, they're not getting the specimen, they're not getting the urine, that they're getting the results, that we are stating that the urine has not been compromised and that it has been in the custody of everyone who touched the specimen or who had contact with the specimen. Now, anyone who shouldn't be a part of the chain of custody should not touch the specimen. If they do, it compromises the integrity of the specimen. So going back to the random collection. So random collections are urinary specimens that are collected at any part of the day. The patient simply comes in and they collect the urine. The most common, again, type of test that we utilize random collections for would basically be for drug testing. Keep in mind that sometimes you'll do a random test for individuals who are having urinary issues at the office. However, when it comes to checking for bacteria, especially if the patient has a complaint of scanty urea or dysuria, scanty urea, oliguria means small amounts of urine, having the urgency to go to the restroom, but producing small or tiny amounts of urine. Dysuria means difficult. Dys means DYS means difficult, and urea means urine. So for people who also are having a difficult time urinating, we would actually do obtain a urine specimen. So sometimes this would be a random urine specimen, although we would really want this to be what we call a clean, which brings me to number 3, a clean catch midstream. This is called clean catch midstream. A clean catch midstream urine is typically used for CNS, which stands for culture and sensitivity. Culture and sensitivity is urine that we're going to actually send to the microbiology section of the lab so that they can culture the urine to see if there's any bacteria growing inside of the patient's urine that's giving them the issues or the problems that the patient is presenting at the physician's office. So a clean catch is when the patient is given 2 antiseptic towelettes. This is to clean the labia or the penis. If the penis has extra skin, say the male had not been circumcised, you would instruct, yes, he has a anteater penis or a elephant nose penis, but either way, you're going to instruct the patient to pull back the extra foreskin and cleanse the penis. This is to remove any bacteria, external bacteria from the outside of the genitalia, so that when the patient starts to urinate, none of the outside bacteriums will get inside of our specimen, giving us a false read. So back to the clean catch and how the collection method should actually be collected. So if it is a male patient, you will want the patient to clean the penis, clean around the head of the penis, okay? Also probably would instruct them to clean the shaft of the penis, because some people like to put the whole penis in the cup. Don't understand why a person is going to put their whole penis in the cup, because that would definitely be incorrectly, because the outside of the penis can interfere and bring us pathogens or bacteria into our specimen, which would then compromise and give us a false. Okay, I'm moving on. I think you got the point. Okay, so a little fun while we talk about it. So they will clean the genitalia with the antiseptic wipe. Okay, this antiseptic wipe is to inhibit the growth of the bacteria, cleanse the external bacteria from the genitalia so that it will not influence or compromise the specimen. Once the genitalia has been cleaned, if it's a female, then she would wipe from front to back with 1 towelette per side. Meaning, since there's 2 lips, 2 labias, the female would need to have 2 antiseptic wipes to clean the area of the genitalia, wiping from the front to the back. Then the patient, both male and female, will start to urinate, okay? Expel the urine into the toilet. Then they would take the cup and they would catch the specimen midstream. So they would go ahead and start this urine, making sure they don't expel fully the bladder. But once the urine is started, they will then take the cup and urinate inside of the cup. What we've done is we've cleansed the outside of the genitalia, then we expel some of the urine so that we can fully get some of the external bacteria removed, and then they're going to collect the rest of the urine inside of the collection container. Keep in mind, you don't want the penis to lay inside of the cup. You don't want the vaginal wall of the vagina or the pubic hair of the female to lay this cup or rest the cup right up against the vagina. You do not want the cup or the collection, and usually it's a cup, to touch the patient when it comes to a clean catch midstream. The rationale is we don't want any excessive contaminants, outside internal contaminants, to get inside of the cup and allow our culture and sensitivity to bring us or to register a false positive. Again, this is called a clean catch midstream. This is for culture and sensitivity sent to the microbiology part of the lab. Okay, usually this is done to assess UTIs, urinary tract infections. Okay, and it's very important for us to know what type of bacteria is actually influencing the area or the urinary system, so that the physician can prescribe the right antibiotic. The next urinary collection method is called a catheterization. This is where they actually will get a sterilized sample. They will take a catheter and they would insert it inside of the genitalia area and go straight into the bladder wall. This is producing a sterile urine. The problem with a catheter is that oftentimes after the catheter is removed, the patient gets a UTI, a urinary tract infection. That's why it's very important for catheters not to be placed within the bladder for more than 3 days. Most of the time, the catheter is removed upon discharge, making it hard for us to assess if the patient is going to, in fact, get a UTI. So a lot of times the doctor sends the patient home with the prophylactis, which is an antibiotic, just in case the patient does experience some urinary issues due to having the catheter placed while they were inpatient or in the hospital. So why do they use the catheter instead of any other urine collection method? That's a great question. Again, when the doctor is in is worried about the sample being compromised, he might decide that it would be best to to get the urine straight from the bladder. Sometimes this is also done for cytology studies. Another way to aspirate urine is to take a needle, and this is called suprapubic. Okay, suprapubic collection. Okay, and the suprapubic, suprapubic collection method is when they take a needle, a nice size needle, and they take the needle straight through the skin into the bladder from the outside of it's going straight through the pelvic into the bladder. This is also used for cytology studies. This is where they're aspirating the urine straight from a needle out of the bladder right into a syringe, and they're studying it under a microscope. I've never had the opportunity to do that, but that is a collection method. So we talked about first morning void, utilizing that for pregnancy testing. You will do a pregnancy test today. Unfortunately, your collection method would be the random because although we're in class, we just want to get a urinary specimen. But if you were going to do a culture, and you'll be doing a urinary culture today with your urine, which will be where you'll just be collecting it and prepping it to send to a laboratory such as you would do in a POL, physician's office lab. So in the this would be utilizing a mid-catch, a clean catch midstream. We talked about how we collect a clean catch midstream. So we have first morning void for pregnancy testing. We have random for drug testing. We have the clean catch midstream that is usually used for CNS, culture and sensitivity, especially if a patient is coming in saying that they are having urinary issues, and they think they might be in fear of having a UTI. Then we have the catheterization. This is for a sterile type of urine collection, and the physician might want to do cytology studies or something to look at the urine or the cells of the urine in the bladder. And then we have suprapubic. Now, I did tell you that one of these collection methods, and then we have the random, okay? This is usually done for medical legal events, and this is where a patient would have to have a chain of custody and sign. Usually for urinary collections, there is nothing but more of an implied consent, but when this urinary collection has something to do with the drug testing or employment, the chain of custody has to follow. Then we have to get in a more express consent from the patient, is where the patient actually expresses their name by signing their name to the chain of custody document. A chain of custody document is kept from the time of collection to the time of disposal, not the time you actually pour the urine out of the container that is collected in. No, what it means when I say from the time of collection to the time of disposal, disposal meaning when the judiciary system no longer needs to have access to that sample. That is how long the chain of custody continues to keep going. So that means every time a different hand touches the specimen, there must be a signature expressed to the chain of custody form, keeping up with each person who's actually came in contact with the actual chain of custody collection. So you will today use reagent strips, and this will be done with a random collection. So what are the reagent strips? That's a great question. So the reagent strips is when it comes to urinalysis, okay, there are 3 different types of urinalysis. We have what we call the physical UA. This is where we actually look at the color of urine, we actually look at the odor, smell for the odor of the urine. We look at the volume of the urine, and we look at the turbidity. 4 things. These are the 4 components within a physical UA. And in physical urinalysis, one more time, we look at the color. Color, when it comes to urine, can range anywhere from a pale color all the way to a amber or a red color, okay? A pale color could actually mean that the patient is well hydrated, meaning they're drinking a good sufficient amount of water. It can also mean that the patient's kidneys are about to shut down and they probably need dialysis. So it doesn't always mean that they're hydrated. So you can have pale urine when you're very hydrated, and you can have pale urine when your body is about to go into where your kidneys are about to shut down. We hope that's not the case. We hope you're very hydrated. The next thing that, and the color of the urine gets its color from an enzyme called urochrome. Uro meaning urine, chrome meaning color. The amber color urine, when we go from pale to yellow to amber, would actually mean that there is blood in the urine. Of course, if it's a female and she's menstruating, well, that is the #1 reason for blood being in the urine. Blood typically typically should not be in a urine specimen. It would be simultaneous of some type of internal damage, that the person is bleeding internally, and then here we have a major issue going on. All right, so physical component, we talked about the color. The next thing is odor. We smell the urine, and the reason why odor is going to be important.
I didn't understand that.
It's because you wasn't supposed to understand. One of the reasons why odor is important is because we're able, especially if a patient has diabetes, you can actually smell a sweet smell coming off of the urine, because a person that is diabetic, their urine tends to smell sweet. Also, we have foul smelling urines. Urine can smell like fish, which could be indicative of some type of sexually transmitted disease or some type of infection going on. Urine can have more of a mousy or musty smell, and this could be large amounts of phenylketonuria or enzyme in the urine. So the odor of the urine actually gives us an indicator of what could possibly be going on in the patient's body, and it's part of the physical component of the urine analysis. The next thing is the volume. How much urine is being output within a 24 hours. Now, the cups that you have in front of you, I'm sorry, I don't have one of those cups in front of me. So I would say that maybe this cup is a 10-ounce cup. It's kind of wide. So if it's 10 ounces, typically what we have in a 10 ounce in a 24-hour day in an adult, they can expel anywhere from 1,600 milliliters to 2,000 milliliters of urine a day in 24 hours. This is an adult. So looking at your cup that you have in front of you, you should have that cup now with the green top. Looking at that cup, if this in that cup is, I want to say 100 mLs, so that would mean if you're an adult, you would have anywhere between 16 to 20 of those cups would be the equivalency of urine expelled from an adult within a 24-hour period. Adults expel more amounts of urine within 24 hours, and they go to the bathroom less frequently. Now, a child on a normal will expel anywhere from 550 to 750 ml. So you're looking at anywhere between 5 and 8 of those cups. Okay, now a child is going to expel less urine in 24 hours, but they're going to go to the restroom a lot more frequently than an adult. So it's going to appear that they're going to the it might appear, you might start to think that this child is peeing all day, that they're expelling more urine, but they're not. They're actually producing less amounts of urine. They're just expelling it in a much more frequent rate than an adult would. Okay, so when it comes to the volume of the urine, we're trying to make sure that the child is actually expelling, the bladder is expelling what we call the average amount of urine that should be expelled within a 24-hour period. So then this would be what we call a quantitative type of assessment when it comes to volume. And the last thing is called turbidity, and that's turbidty. turbidity, turbidity. And the turbidity is how cloudy the urine is. So if you pick the urine up and you can see straight through the urine, it's really clear. You can look through the urine and see through the other side. It's less turbidic. But if you was to pick the urine up and it was very cloudy and you wasn't able to actually see straight through the urine, it seemed like it had a lot of substance in it, this would be a person with a lot of turbidity in the urine. It just means that this urine has a lot of substances floating around in the urine, and it's clouding the clarity of the urine. So we want to also look at the turbidity of the urine. All of these are what we call physical components of urinalysis. Okay, let's go back over it. We have color. Okay, we have the odor, we have, after the odor, we have the volume and we have the turbidity. Those are the physical aspects of a UA. The next aspect is called the chemical component of a UA, and that's what you're going to do with the urinary, with the UA strips. Each one of those cubes today is impregnated with a certain enzyme, and once that enzyme encounters the urine and is present in the urine, it will change the cubes to a different color, in which you will read the actual color chart, the chart, and you will be able to assess what's happening with your patient's urine. So we're going to start at the bottom, and we read the actual chemical components from the bottom of the dipstick to the top. And the very first cube at the bottom is called glucose, and a person with glucose in their urine, oops, sorry people, little slip, is called glycosuria. Okay, when they have glucose in their urine, it's called glycosuria. So glycosuria is the evidence of sugar in the urine, meaning that the body is producing insulin as it should, but it's not getting rid of it in a rate, and it's spilling over into our urine. So everything that we eat, we know that it breaks down all the carbohydrates. No matter what you're eating, it breaks down to sugar, and sugar is the fuel that we use to burn our system. If our body is unable, the pancreas is unable to break down the sugar, or the quantity of sugar that we're ingesting, then it spills over, and we start to have what we have, an abundance of insulin or glucose in our system, and a person is deemed to be diabetic. So remember when I told you about the physical component, where you actually can smell the actual sugar, the glucose in the urine, and have a sweet smell. It will also register on the chemical side as large amounts of glucose in the urine. Okay, so this could be a sign that we're dealing with a patient with diabetes. After that, and we usually read glucose at 30 seconds. And then the next strip that you'll see, 30 seconds, is called bilirubin. Now, each one of these chemical cubes, each one of these cubes is like a roadmap. It's going to tell the physician exactly what part or what organ to be looking at in the system. So we talked about glucose, where the pancreas, to check the pancreas. This is where, if it's showing up, this is where the patient is having the issues. So then bilirubin is the liver. So if your bilirubin shows up in your urine, then the issue is at the liver. So people with bilirubin issues, their inability to break down the bowel. When it's a baby, you've heard of the term jaundice, and they put them under ultraviolet light to help the liver break down the excessive amounts of bilirubin. So this would be indicative that we need to check the liver, and that's usually read at 30 seconds. After bilirubin, we have ketones, and ketones, normally a person is spilling ketones when they're on a starvation diet, or when they're doing like a high ketose fat diet, changing their sugar burning system into a fat burning system by eating large amounts of fat, and then it spills out as ketones and making us ketonic inside of our urine. But if they're not on a low carb, high fat diet, then the spilling of ketones can be indicative of starvation. They could be an anemic bulimia. They not anemic, they can be anorexic, suffering from a condition called bulimia, or they could be having some issues where they're excessive vomiting. Say they're pregnant and they're doing a lot of emesis, or having a lot of vomiting issues, emesis issues during their pregnancy. We'll notice that they will have high ketones intake, because of course when our body starts to be deprived of the nutrients, we go into starvation mode, and then that also is where we start to spill our ketones. So ketones are normally read at 45 seconds. So after ketones, we start to see blood. Okay, blood in the urine could be indicative of, again, if it's a female, she's on her menstrual, and if she's not on her menstrual, then it could be indicative of internal issues. We do not want to have blood spilled in our urine, and you'll notice that on the chemical dipstick, it'll start being spotty. You'll get like, it's orange naturally, and then when you dip it, it'll start turning like green, or spotty all the way to brown, the more blood that's in the urine, the higher it will read on the dipstick. And so that just means that there could be some internal damage going on. So you don't typically want blood to be in the urine. Now, if it is a female, the first thing we want to ask her is if she's menstruating. Sometimes we can tell just by looking at the urine, because the urine will be expelled depending on where she is in her menses, what stage she's in, whether it's the first day or the first couple of days versus it going to where the menses is actually going off, her menstrual cycle is going off for that month, then it might not be more evident to see it inside the urine. But if she just started, sometimes we can see it because the urine will be more amber or red color in nature, and you can just tell right then, and that's a telltale sign. A lot of times people who are expelling gallstones and having gallbladder issues, male or female, or any type of kidney stones, any type of kidney stones, not gallstones, any type of kidney stones will also see that, and they're expelling them in the urine, cause bleeding within the inside, and it'll be spilled out in the urine. We can see it that way as well, and it'll also produce a bloody like urine specimen as well. Sometimes it's not as evident, and we can't see the amber color, but it'll show up on the reagent strip. So again, this would mean that a person is suffering from some type of internal bleeding, and so that is very important. The next thing that we see on a reagent strip after blood is we see protein. It's called proteinuria. A lot of times a pregnant woman expels protein in her urine. It can be quite natural. However, we don't want to have large amounts of protein. Bodybuilders, people who do a lot of excessive weight bodybuilding, muscle building, tearing down the muscles and building them back up, sometimes spills protein. No, you can't drink protein shakes and all of a sudden have large amounts of protein in your urine. That is not how that works. But if you're weight training and you're doing excessive weight training, sometimes we notice that people that do excessive bodybuilding, that breaking down of the muscles and rebuilding actually spills protein. That can be a bad thing. Large amounts of protein can cause internal damage to the organs. I know I said this video was going to be short, and I'm already at 30 minutes, so let me kind of speed this up. The next chemical component that we'll see is called, in our urine, is called urobilinogen. Urobilinogen is the intestines, okay? Let's go back. It's specific gravity. And specific gravity, same thing I talked about, that turbidity. Specific gravity should be compared to distilled water, which is bottled water, and that should be a comparison of 1.00 is what the urine, when we compare our urine, they want it to be the comparison of a distilled water bottle. So if you was to dip a water bottle, you would notice that your specific gravity on a water bottle would register, the water would register at 1.000. So the more hydrated you are, the more closer to that bottle of water your specific gravity is going to be. Now, the more dehydrated you are, or the less hydrated you are, you're going to see that you have a higher specific gravity. A lot of times, our specific gravity is going to be a much higher in the morning. Remember, the turbidity, the substances, it settles in our bladder. Because of that settlement of substances in our bladder, it does cause our specific gravity to be more on the higher side. But as we go throughout our day, we hydrate ourselves and we urinate and expel our urine, our specific gravity should get closer to that 1.00. Now, after specific gravity, we have urobilinogen, and urobilinogen speaks to the intestines, okay? So we talked about bilirubin for the liver, now urobilinogen for the intestines, and this is read at 60 seconds. Okay, so at a full minute. And so here you go with the urobilinogen. Again, it could be some issues going on with their intestines. Again, everything that we do when it comes to our chemical reagent strips is to give us a roadmap at what organ we should be looking at. So after the urobilinogen, we have nitrates, and nitrates is bacteria. So usually, I don't know if those of you who've done home test, UTI test, they went to the store and they're going to buy them some AZO pills, and they have the AZO test in the store, and it comes with a dipstick and you pee on it, and if the nitrates show up, it's a key indicator that you have a urinary tract infection. That can very well be the case. So nitrates show up when we have bacteria in our body, and so nitrates is a bacteria. Now, sometimes those nitrates can be a false positive, and how that works is when it comes to urine and actually assessing urine, it needs to be assessed within the hour after void. Anytime after that, but the actual urine builds up bacteria, okay? And so therefore now when you dip that urine that's been sitting out a while, that urine is going to have a high concentration of bacteria or nitrates, which would be a false positive. Doesn't mean that the patient at all has some type of UTI or something going on. It's just that urine has sat out long. And think about when you're in a nursing home, or if you know somebody that's a bedwetter, and when you go into that room, you could have cleaned the sheets, you could have done a lot of different things, but you still have that presence or that smell, that ammonia gas smell of urine. Those nitrates is what gives off that ammonia smell, and that ammonia smell is what gives us the actual the night, which builds is because of the nitrates are being built up. So if any time that you're going to be doing a urinary collection method, and you know that you're not going to be able to assess that urine within that hour, then you need to take that specimen and put that specimen inside of the refrigerator, and that's going to minimize the buildup of nitrates. Now the last part is red, or the last cube or chemical on the reagent strip is called leukocytes, and it's read at 120 seconds. And a leukocyte just is a white blood cell, and of course white blood cells are present when our body is fighting off an infection. So the presence of nitrates and the presence of leukocytes would be indicative that the body is actually fighting off some infection. Could be a UTI. Now this is where that culture and sensitivity and that microbiology collection of the culture and sensitivity for that urine culture becomes very important, because although they do have some type of bacteria, and there are leukocytes marching in our body system to let us know, wow, there's an infection going on, we don't know what type it is. And so in order for us to know what type of bacteria is actually influencing the infection, so that we can give them and prescribe them the right medication. Bottom line is, if you give somebody the wrong antibiotic, they won't get rid of the bacteria. Therefore, they'll continue to have that bacteria going on, and that infection and those leukocytes will continue to be present within the urine. So that is called a chemical urinalysis. We talked about glucose, we talked about bilirubin, we talked about urobilinogen, we talked about blood in the urine, we talked about ketones in the urine, we talked about protein in the urine, we talked about nitrates in the urine, we talked about urobilinogen, and we talked about leukocytes in the urine, and the importance of why they're there. So I hope you were able to understand that. Now the third component of the UA, so we talked about the physical and the chemical, and the last one is called microscopic. Unfortunately in class we're not going to be able to do a microscopic urine, but basically what that is you would actually take the urine and look at it under a microscope, and this is where you can see certain things like crystallization and casting under a microscope. We don't be able to do that. I'm not sure if you'll be able to do that at a POL, which is a physician's office lab. Usually the physician's office lab, they have lower clear complexity, and a lower clear complexity does not allow for the microscopic evaluation or microscopic urinalysis. So the urinalysis that you are going to become accustomed to doing on a regular is either going to be the physical UA and the chemical UA, in which you would experience those today. Shortly after watching this video, you are going to dip 2 urine dipsticks with 2 different urines in the room, and then you are going to calculate your findings, all right? Based off of what you see with your UA charting sheet. So we talked about the different type of urinary collections, the reason why we have those different type of urinary collections. We talked about the different types of the next thing that I want to talk to you about is called timed urine specimens. A timed urine specimen is when the doctor actually sends the patient home with a large container. The thing that I want you to remember about timed urine specimens is, again, remember, when urine sits out, it builds up nitrates. So to avoid those nitrates being built up, then you need to make sure that when the patient voids in usually a smaller container and then pours the urine into a larger container for a lot amount of time, usually 24 to 48 hours. What the doctor is trying to assess is how much urine, again, the patient, the quantitative amount of urine that's being expelled in that amount of time. And so the patient is then taking the urine out of the small container, pouring it into a larger container, and in this larger container is being kept in the refrigerator until that time is exhausted. Make sure that you remember to tell the patient that the first time they start that time urine collection, that urine needs to be poured out. You don't want to pour the very first urinary collection inside of the large container. Make sure to remind the patient that that container needs to be refrigerated. Yes, that's right. They need to keep the urine in the refrigerator until it is time for the urine to be brought back to the office for the evaluation of the urine, keep in mind that the collection cup should never be labeled. The label should be affixed to the body of the collection, whether it's the collection cup that you guys are using today, or because if you was to put the label on the top, once the top's twist off and removed, now the specimen is unlabeled, and this is where we get that pre-analytical error, where we can no longer identify whose specimen is, especially if we have several cups of urine and all of them have been labeled on the top. Once the top is removed, there's no way for us to acknowledge or recognize whose urine we're actually assessing. So the urine label should always be on the body of the cup and not on the top. So even when the patient goes home and they're taking their big urinary collection bottle home, they do not need the label. Again, needs to be affixed to the body of that urinary collection container and not the top, because once that top's removed, now we cannot identify whose specimen that is. I don't care if you know whose it is. It's just not recognized by CLIA as a white appropriate way to identify urine. So we don't want never to label the top of the urine. Okay, we've come to the end, and now it's time for you to do your urinary collections. Today, you should be doing a pregnancy test, and you should know right now that that is usually done with the first morning void. You also should be collecting a UA culture. This is where you're going to use the pipette and the little evacuated tube. You'll notice that the evacuated tube has a yellow label on the top. It is gray stopper, and it looks like a little peel is on the inside. That peel is a preservative that's going to help preserve the urine once it goes inside of that ETS. The reason why the label is yellow, because we also have a gray ETS for blood collections, and we want to differentiate between the blood collection ETS and the urinary collection. So all urinary collection ETSs have yellow, and then you'll look at it, you'll notice that the word urine is written across the top, so you know that that is a urine ETS and not a gray top that has sodium fluoride or potassium oxalate in it. You'll also notice that it'll say on the label, the yellow label, C and S for culture and sensitivity. We do collection of the urinary culture in our office, but we do not analyze. This is sent to the lab with a lab requisition, and that lab requisition will be marked microbiology, and they're going to then grow what we collected in that container and see what type of bacteria, if the patient does have a urinary tract infection. And then we talked about the chain of custody for medical-legal events. I am at the end of the video. You are going to do a chemical urine dipstick. Hopefully by now you'll understand what each one of those chemical components mean and relationship, and you'll also understand that each cube is responsible for identifying an organ system within the body that's either compromised if it actually changes. Now, if your cube is negative all the way down, hey, your patient has a great bill of health. We are at the end of our video. It was 42:15. Okay, I was trying to make it 22:15, but I hope you have a better understanding of what you're going to do today. Thank you, and have a wonderful day in class.